Hi, I'm Dr. Raj. Are you ready to go beyond the pearls? We have a 62-year-old woman is evaluated for an incidentally discovered left adrenal mass. 2 weeks ago, the patient was evaluated in the ER for diffuse abdominal pain and vomiting. A CT scan was obtained that was normal except for this adrenal mass. Oh no! 3 hours after presentation to the ER, the pain resolved spontaneously. Her past history is significant for diet-controlled type 2 diabetes, diagnosed around 1 year ago, osteoporosis diagnosed 4 years ago, and her only medication is alendronate, probably for osteoporosis. On exam, she is afebrile, normal intensive, non-tachy, BMI is 26, and the physical exam is unremarkable. Labs, sodium is 139, potassium is normal at 4.1, and a previously obtained CT scan shows this 2 centimeter well-circumscribed left adrenal lesion with a density around 5 Hounsfield's units. In addition to screening for tests such as for a pheochromocytoma, which of the following is the most appropriate diagnostic test to perform next? So, number one, when you talk about these incidental adrenal masses, is it common clinically? The answer is yes. We see it all the time. So many people are getting PET scans and CT scans. And anytime we worry about this, think about an adrenal mass, what do we worry about? You got it, cancer. And what are some things that make me not worried about cancer in this case? Size. So I guess when it comes to adrenal masses, size does matter. So if it's going to be greater than 4 centimeters, we really worry about malignancy. This one's less than 2 centimeters, so lower on the differential. Something we always want to evaluate is pheochromocytomas, because if it is, we want to take them out, so we always evaluate for it. And the last thing we think about, is it a functional mass? I mean, that is it going to be secreting some kind of hormone? So we already mentioned pheo is getting worked up. What else would we do? So we look at these tests, and which one would I personally not go with? I don't think D is the correct answer, no further testing. We do need to evaluate for something else. What else would I knock off? Probably A, adrenal vein sampling. Why? Well, one-dimensionally as a test taker, that's really invasive for the next best step in management. But why would you even do adrenal vein sampling? Is because you want to evaluate what disorder? That's right. You want to evaluate primary hyperaldosteronemia, otherwise known as a what? A Conn syndrome. And does this patient have any findings of Conn syndrome here? Well, I just switched back to the vignette. The answer is no. And what is a common electrolyte abnormality that we see in Conn syndrome? Oh, you guys are amazing. That's right, potassium. People having low potassium levels. Why? Because aldosterone, it will go to the tubules, meaning that probably the collecting duct, late distal convoluted tubule, and it will dump potassium in the urine and make you retain sodium. So this potassium is normal. People with Conn syndrome are more predisposed to hypertension, and this patient's blood pressure is normal. So in this case, I'm not worried about a Conn syndrome. So not only would I not pick A, I wouldn't pick C. So when we talk about renin and aldosterone, that will be the best first initial screening test for a hyperaldo state. In class, how many types of hyperaldo states are there? Oh, you got it. There are 2. And that's how we get the renin plus the aldosterone. Because if you have a primary hyperaldo state like a Conn syndrome, you can imagine that the aldosterone will be very, very, very high and the renin will be low. But if you have a secondary hyperaldo state that you see commonly in people with CHF, nephrotic syndrome, cirrhotics, they also will have a high renin and a high aldo. So, but I'm not worried about that. What I would pick for the right answer is letter B. Why is B correct? Is what are things that make me worried about a Cushing syndrome? Well, it's very strange that at age 62, she was diagnosed with type 2 diabetes at only a year ago. And even more odd is that, she was diagnosed with osteoporosis at age 58. Usually we screen for osteoporosis at what age class? That's right, 65 years of age. So this is early. These are going to be risk factors of having high cortisol levels. So the answer is going to be B. So what I want to teach you folks is that how do you work up a Cushing's patient? Very triple star high yield for your board exams. Is that when we talk about screening tests, as you could tell, it's a very long diagram because it's a very extensive time consuming workup. So we usually do 2, if not 3, if not 4 screening tests altogether before embarking upon this long workup. So what are going to be some FDA-approved screening tests for a Cushing's evaluation? Well, you could do a low-dose dexamethasone test. You could do a 24-hour urine cortisol. You could also do a 11 p.m. salivary cortisol, because that's when cortisol should be the lowest. Or you lose what's called a diurnal variation in cortisol, meaning that cortisol should be very high in the morning and very low at night. You lose that. But according to this diagram, you do a 24-hour urine cortisol first, and then that will tell you that if it's elevated, is it going to be physiologically elevated or pathologically? If you worry about pathologic, you consider doing a low-dose dexameth then. If you suppress, well, then it's going to be physiologically elevated. If you don't suppress, then it's pathologically elevated. Then the next question becomes, where is the pathology? And that's where the ACTH level will help you immensely. If the ACTH level is normal or low, then you know it's an independent type process where you may have a tumor in the adrenal just popping out cortisol. If it's dependent upon ACTH, well, it mainly could be 2 places. Number 1, the pituitary, and number 2, ectopic, and this is where the high-dose dexamethasone test suppression could help you. If you suppress, you think about the pituitary, and that's what we call Cushing's disease. If you don't suppress, then you think about an ectopic location such as the lungs, such as the small cell carcinoma type tumor of the lungs itself. So think about some classic physical findings of a Cushing's syndrome that will appear on your board exams. I gave you some of the classic abdominal striae, the dorsal fat pad, the moon facies, and a couple beyond the pearls tips for you. Number 1, if you have hypercortisolism in a Cushing's syndrome, the treatment's always going to be take out the tumor, surgically resect it. If there's a delay in resection or you can't resect, then we think about medical management. What would be one of the first-line drugs for a Cushing's syndrome? Ketoconazole, the antifungal. And how does it work? Well, it actually inhibits the conversion of 11-deoxycorticosterone into cortisol. But remember, like many of the azoles, you got to be careful in patients who have liver failure or liver irritation. And last but not least, it's time to go beyond the pearls. So one of the electrolytes that you would look about would be bicarbonate. And people who have a Cushing syndrome may have an elevated bicarbonate, causing a metabolic alkalosis. Why? Is because you may have some aldosterone effect. And remember, we mentioned aldosterone dumps potassium out in the urine. It makes you retain sodium, but people tend to forget it also makes you lose hydrogen ion. And because you're dumping out hydrogen ion, you develop a metabolic alkalosis. I hope this walkthrough through endocrinology and Conn syndrome and Cushing's disease has helped you. If you want to get more information like this, see me in my live review course at The Pass Machine and go to my website, beyondthepearls.net. I'm Dr. Raj, educating you today for a better outcome tomorrow.